Welcome to a slide presentation from Dental Assisting LC, which is geared toward the dental assisting student. This presentation deals with radiographic interpretation of dental materials, oral pathology, oral conditions, dental disease, and foreign objects. You may be wondering why this is important to the dental assistant, because after all, in most states, dental assistants are not allowed to diagnose patient conditions, only the dentist and the hygienist in some states. But it is important for us to see our result on a radiographic image and to know that we have a diagnostic quality image or images. And I'm always pushing that point as a dental assistant that we have diagnostic quality images. That allows us to avoid retakes. So we are practicing ALARA as low as reasonably achievable for our patients. And it allows us also to communicate with the dental staff in regards to patient treatment and patient cases. And sometimes it does assist us with patient education if a patient is asking us about certain conditions on an x-ray. Again, you don't want to be diagnosing, but if a dentist or a hygienist has already explained that to the patient, sometimes the patients still have questions. And depending on your dental practice, you may be the one to answer those questions for the patients. First, let's look at a comparison of some important terminology when we're interpreting a radiographic image. We need to be able to determine the radiographic appearance of a clinical appearance. So that term clinical appearance means what we actually see in the mouth visually or perhaps on a photograph, an intraoral photo or a photograph, versus what we see on a radiographic image, what the appearance is, and how those two actually relate. We also need to be aware of what normal anatomy looks like on a radiographic image so that we can determine that we have that quality image, or are there deviations or anomalies to the patient structure, the patient's oral cavity, their dental anatomy, so that we can discuss with the doctor. Maybe the doctor wants to know, hey, what's going on, in a very casual manner, and so you are able to identify some dental anomalies or deviations. And then we've had these terms before in another slide presentation. What is radiolucent versus what is radiopaque? So radiolucent means that it was a structure that does not have density or high density, and the x-rays pass through it, and so the area looks very dark gray on a radiographic image, whereas radiopaque, we're thinking of structures like bone, dentin, enamel, dental materials that are radiopaque, so they're very dense. So there's some resistance to the passage of the x-rays through those types of structures or materials, and therefore the image looks like a lighter in color, lighter in contrast image on the radiograph. So let's look at what dental materials look like, such as metal, on a radiographic image. And I did take some of these from the internet. Here are some good old-fashioned amalgam restorations. You can see that they are radiopaque on a bite wing image here, and so it would be good for the dental assistant, the radiographer, to be able to interpret that these are indeed amalgam restorations. We're not going to say what's happening with them because that's diagnosing, but just that we can identify that they are metal on the image. Since stainless steel is a metal, this is what the radiographic image of a stainless steel crown would look like. Also, if you have any porcelain fused to metal crowns, they would also appear in this manner, and all of these are radiopaque. Okay, radiopaque. And again, this presentation is just about being able to recognize anything from what would be normal dental anatomy on a radiograph. Other dental materials, we have a 3/4 actually gold crown. So what you're seeing on the radiograph is all of the metal, all of the gold alloy. Now this other image here, part of the image is, of course, an implant. So an implant is metal. As these two, the photograph and the radiographic image were taken at 2 different times. So while tooth number 14 has a crown, you do not see the crown here. It doesn't mean the crown's invisible. It just means that they were taken at 2 different times. Another source of metal on teeth is sometimes orthodontic fixed appliances, and you can see if they were radiographed that they would also be radiopaque. Composite and porcelain, how do we interpret those on a radiograph? Well, here sadly we have a photo of some fractured central incisors, and for the restoration of these teeth, we do have composite, but they were reinforced with metal pins. So you can see the composite in this case is radiolucent. You don't see that here. Here is a tooth with a composite restoration, and it is slightly radiopaque. Back in the day when composites were first being used, they tended to be radiolucent. So you might look at a radiograph and think, this person has rampant decay, but maybe they really had composites, where now the composites are somewhat radiolucent. Here is a full porcelain crown. Again, somewhat somewhat radiopaque for composite here, and also somewhat radiopaque for the porcelain crowns. Again, it's somewhat radiopaque. Some of our dental cements also have radiopacity to them, radiopaque. So here's some calcium hydroxide. You can see that it is radiopaque. The way the chemistry of it is developed is so that it's radiopaque, and endodontic sealer is radiopaque as well. Let's look at developmental anomalies that you may see on a radiograph so we can interpret them properly and not think that something happened to our x-ray image, that improper technique was used. So, or if you're a new dental assistant, just so that you are knowledgeable about radiographic interpretation. So in this radiograph, we see some space, and if you bring to mind your dental tooth anatomy, we see that there are 2 central incisors and a canine, but we don't see any lateral incisors. So that would be what we would need to interpret from this periapical. When we look at this periapical, what are you seeing? If you thought supernumerary tooth, you are correct. So we see premolar, premolar, molar, molar, and then here's this premolar. I would venture to say that in the positioning of this radiograph, this supernumerary premolar could be impacted and not visible, not clinically visible in the oral cavity. It's a good chance it's impacted. Here we have a anomaly that we see a crown that kind of looks like it has two parts. That could either be fusion, where you have two tooth buds that have separate roots but the crown grew together, or a gemination, where you have a single root and then you have a crown that really has developed, or maybe not fused, during the development of the crown. And then that's what it looks like radiographically. So if you were unaware of what a gemination tooth or a fusion tooth look like on a radiograph, you might think that the patient moved and you have a blurry image, which is still possible, but not quite in this degree. Another importance of being knowledgeable about radiographic interpretation. In these radiographs, we're just looking at apical disease or pathology or conditions. So here we have a dilaceration, a root that is curved. There may be some cementosis here, so extra cementum that gives it kind of a thick look to the root of the tooth. This is probably an abscess, so we have some bone loss here on this particular molar. Some other pathologies may be a cyst here in the sinus area and also in the mandible. And then on this bite wing image, this mixed dentition bite wing, we see that the root of this primary molar is resorbed, and so this tooth was getting ready to exfoliate, and so this is a natural occurrence. Again, if we are unknowledgeable about radiographic interpretation, you immediately might say, I don't see the root there, let me retake it, which would be incorrect, right? Because this is a natural occurrence for the life of a primary tooth. Some other tooth conditions, so clinically we see an impacted molar, and our panoramic image is a good image to actually see impacted third molars. Again, the diagnosis is for the dentist and the hygienist, but we would be able to verify that we have a diagnostic quality image by being able to identify all third molars here on this panoramic. Now we have a clinical view of our friend, the mandibular tori. I'm sorry, I'm joking. I'm only joking because we know as dental assistants taking radiographs that a person that has mandibular tori is very challenging to take a radiograph. Not impossible, but very challenging. So we have small mandibular tori in this photo and a very large mandibular tori. Remember that tori are bone, and they are not quite as dense as some of the other bone that we have, or I will say in this particular case. So you can see a shadow of the tori, of the bone, here across the root structures of these mandibular teeth. And again, if you're not knowledgeable, if you haven't educated yourself on radiographic interpretation, you might think that this was an error in your periapical. Some other dental conditions, it would be a fractured tooth, and then how that could be interpreted on a radiograph. You can see the fracture very clearly. Ouch, that's a pretty serious one, through the furcation, through the root. And here is another root fracture. I'm going to reiterate the importance of interpreting radiographs. If you were using traditional film, in this particular radiograph, you might think that you have a bent film error here. And then radiographic foreign objects. Again, not for us to diagnose, but just to be aware. Anyone know what this is? This is a burr that has fractured and embedded itself in the mandible. Here we have commonly known an amalgam tattoo, and radiographically, because amalgam is metal, it's radiopaque, we see the fleck or the little speck of amalgam that is in the retromolar area on the mandible here. Now let's look at interpreting dental disease, caries, and periodontal disease. I am going to repeat that in most states, dental assistants do not diagnose, but it's very helpful for us to have the knowledge of recognizing or interpreting dental disease on radiographs. First, some dental caries terminology. So dental caries are either classified or sometimes they use the word categorized by the level or the depth of the dental caries, and also by location, which has to do with the tooth surfaces. So let's look clinically. We might look at a tooth and it has some deep fissures here, that's for sure, and grooves, but perhaps it is just a beginning decay that is diagnosed by the dentist or the hygienist. So that would be classified or categorized as incipient decay. Usually it's in the enamel, but not quite through to the dentin. If you've been in dentistry for a while, this is what dentists used to call out as a watch, which is really not so popular anymore. Usually the tooth is restored in a very conservative way. Then we have moderate. This is actually a pretty large decay, but radiographically you can see that it is through the enamel and the dentin. So this could be moderate to advanced. Our next slide shows severe decay for sure. You can see it's into the pulp chamber. Here is decay on the distal area, so we're also remember about location, and this is actually onto the root of this tooth, so this could be termed as a class 5 or a cemental cemental caries or root caries. Another term is recurrent caries, so caries that develop underneath an existing restoration or a crown, and that would be recurrent caries. Now let's look at the importance of proper technique in exposing a radiographic image so that we are not either disguising a caries situation or a caries condition, and then we'll see some in a couple of more slides in improper technique or just conditions that could possibly think that there's a diagnosis of caries. So here we have foreshortening. You can see where you can see a lot of the occlusal surface in this radiograph. I call these like mushroom teeth. So you have the root, and then all of a sudden it just kind of bulbous and bulbs out. You really want to see more of like the profile, the facial of the tooth. So here it looks like, okay, a very clear dentin and enamel and dentin, but upon a better correct angulation, you can see that there's actually a small dark area here, incipient or just a beginning decay. So having good technique, proper technique, is really important for the doctor to diagnose. Here we have overlapping. Now, overlapping can actually hide the proximal surfaces, so we want to make sure that our horizontal angulation is correct. And then let me go back to the foreshortening error. We want to make sure that our vertical angulation is correct. This also, overlapping, could hide the fact that an existing restoration maybe has an overhang where it wasn't quite properly finished, that restoration finished to the tooth structure. So technique is very important. Now we can look at some areas or effects that could be misinterpreted as caries. One of them is cervical burnout, and this is where at the cervical or the CEJ area of the tooth, in some people's teeth can be very thin. Remember that, and not very dense. So remember that that would result in a radiolucent area that could be misinterpreted as caries. Also, when you have overlapping, we have an effect called the mock band effect. And what the overlapping does is that it actually displays a shadow on either side of the overlapping, which could be misinterpreted also as caries. So here's where the technique is also very important. And then we have a interpretation that this tooth looks very healthy, but here on this radiograph, it looks like it could be decay. Now, that in fact could be the case, or this could be a composite. So just another interpretation of the radiograph. Now let's look at periodontal disease on a radiograph. So we have some terminology for periodontal disease. We have gingivitis. Now, gingivitis involving inflammation of the gingiva. Is gingiva, is that tissue radiographic or not? It is not. Soft tissue with our standard periapicals and bite wings and even a panoramic do not produce enough radiation to actually see gingiva, so it is not radiographic. Periodontitis, radiographic or not? Yes, it can be, because periodontitis is the inflammation of the periodontium, which involves the alveolar process, which can be affected. There can be bone loss in periodontal disease, and that is definitely viewed or interpreted on a radiograph. So what kind of radiographs as dental assistants or radiographers do we need to take in order for the dentist or the periodontist or the hygienist to see potential or to see periodontal disease? So we need to have a PA that represents the long axis of the tooth. You can see here that the bone level, which should be somewhere near the CEJ, this bone has receded, so this is definitely an indication of periodontal disease and bone loss. This image is a little dark, this one's a little clearer, so you can see a pocket here that has been formed from bone loss due to periodontal disease. Bite wings are excellent images for a dentist, periodontist, hygienist to diagnose periodontal disease, because of course we can see the teeth in both arches and the bone level. So these are horizontal bite wings. For periodontal purposes or diagnosis, you may be asked to take vertical bite wings. So you can see we see a lot more of the alveolar process in a vertical bite wing. Other images, here is a clinical image of periodontitis or periodontal disease with some gingival recession, and then you can see how that is interpreted on a radiographic image, a periapical, where you see lots of bone loss here. So not sure about this case, what the mobility of the teeth are, how loose they are here in the alveolar process. Here is another image when calculus gets so thick that it's radiolime, and you can see how it affects the periodontium, and we have some bone loss here. So calculus, if it's been on tooth structure for years, usually we see periodontal disease in relation to that. Bone loss can also be described on a radiograph as either horizontal, meaning it usually spans across several teeth and is resorbing at levels. You could think of this as like a wall kind of imploding, right? It's just coming, reducing horizontally. Or we can see vertical bone loss, where maybe it affects one or two teeth, where you have this deep pocket. And this is just another view of horizontal bone loss involving the furcation. So in conclusion, what is the importance of radiographic interpretation for dental assistants? We want to be able to differentiate between dental anatomy and dental materials, oral pathology, and oral conditions. By doing that, we're able to provide a quality image for diagnosis of these conditions and oral disease by the dentist and or the hygienist, and we can assist with patient education. Thank you so much for listening and learning. I hope you're learning from the slide presentations from Dental Assisting LC. Thank you again.